good evening to everyone. I, Dr. Shirley D'Souza, Senior Medical Manager, would like to welcome all of you to this webinar on treatment landscape for acne, present and future prospects, organized by Ajanta Pharma. Acne, as you know, remains one of the most common and a challenging condition to treat. It results in a number of psychological problems like depression, social anxiety, lowered self-esteem, low self-confidence, and with a range of treatment options, we need a proper guidance and expertise to handle each and every type of patient with different skin types. And for that, we have an esteemed dermatologist, Dr. Malvika Kohil, with us today. Dr. Malvika Kohil will be giving insightful guidance on the treatment landscape for acne. She is a consultant dermatologist at Jaslow Hospital and Rich Candy Hospital. She is recognized as one of the eminent aesthetic dermatologists in India. She has been in practice for 27 years. She's the director and founder of Secrets with two clinics in Mumbai. She is one of the sought after educator and trainer for injectables and devices at international and national meets. She's at the advisory board and scientific chair for many educational dermatology and aesthetic dermatology forums and societies in India. She is also mentoring is close to her heart, and she has curated many successful and enlightening CME programs as well as workshops. A prolific orator, she has been invited faculty and she has delivered numerous lectures on varied topics at international and national conferences. She's an invited faculty at international conferences. She has curated various courses, ICMAS, India, and part of the scientific committee and board member of the Indian Alliance, which forms the guidelines. She has also created educational material for aesthetic dermatology and practice guidelines in the COVID era. She is well known to society as a cosmetic consultant at Acne India Fashion Week and Femina Miss India contest, judge at the beauty awards and panelist at both bridal show. Her valued and trusted opinion is sought after by many in India and all over the country and international forums as well. She has authored a number of chapters in IDBL textbook of dermatology, textbook of cutaneous and aesthetic surgery, and other textbooks of cosmetic dermatology. Before I hand over the session to Kohli, I would just like to mention that the questions will be taken after the session. Please type in your questions in the chat box that is given. With this, I hand over the session to Dr. Kohli. Thank you, ma'am.
Thank you very much, Dr. Shirley D'Souza, and a very good evening to all my dermatology colleagues who joined in from overseas. And it's an absolute honor, delight, and pleasure to be part of this initiative by Ajanta Pharma to share our experiences in treating acne, the challenges we face, and the treatment landscape that we have today in front of us, to be able to give our patients hashtag clear skin and scar-free skin. And that's how it goes today. So here I am to share my experiences and my approach. And I'm really looking forward to all your questions. I believe they're really pouring in. And I'd also like to thank the entire team, the AV team, Dr. Shalini Kumar for coordinating this event for me. And I really enjoy the next 45 minutes, sharing my experiences, and then we take the questions. I'm sure we'll have a very engaging interactive session. So thank you. I'm going to share. I'm going to Dr. Shirley, I'm going to screen share now.
Yes, ma'am.
So shall I go ahead?
Yes, ma'am.
Okay. Can you see the screen?
Not Not yet.
Not
Yes,
yet.
ma'am.
Not
Yes,
yet.
ma'am.
Yes,
I
ma'am.
see it. I
Okay.
see it. I
Okay.
see it.
Okay. Okay. Okay.
Wonderful.
Okay. Wonderful.
Wonderful.
So the treatment landscape for acne, the present and future prospects are actually extremely promising. And I'm from Mumbai, India. And Mumbai, as you
Is
know,
the
is the
financial
financial
capital
capital
of our
country.
country.
And
And
a lot
a
of
lot of
techniques,
techniques,
technology,
technology
and
in our city
enterprise
because
starts in
it
our
buzzes, it
city
never
because
sleeps as the
it
city
buzzes, it never
that
sleeps, as the
dreams
city
are made
that
of, and
dreams
it's
are
what
made
makes
of,
people in
and
our
it's
country
what
and
makes
gives great
people in our
careers.
country and
So
gives great
therefore,
careers.
in
So
our
therefore,
in the city of
in
Mumbai,
our
it's like a hub,
in the city of
and
Mumbai,
so
it's
we
like a
get a
hub,
lot of
and
patients
so we
who
get a
are,
lot of patients who are
referrals. They
out of the
referrals. They
city
come
from
from
different parts of the
out of the
country
city, from different
for
parts of the
specialized
country,
treatments for stubborn
specialized
acne,
treatments
difficult
for
acne,
stubborn
and we
acne,
also
difficult
have
acne.
patients who come from the periphery when they're not getting better for our more complex cases, which may not be decoded sometimes. So, this is why we see a very wide variety of cases of acne and scarring in our practice in Mumbai. I have two clinics, one in the north of the city and one in the south of the city. And this is where we do all our the consultations, the treatment planning, as well as all the treatments that procedural management of acne. So the medical as clinical and the procedural management of acne is what we handle. So, according to me, acne today is actually a spectrum inflammatory disorder, and actually it presents with 50 shades of gray, which means that it has a lot of overlapping features, but the key is inflammation. And inflammation presents itself as pustules, as what patients would call whiteheads, cystic acne, sometimes even patients call milia acne, and that's what I had today in the one my last teleconsult today, especially in COVID times. A lot of patients are seeking treatment for acne even online and with online consults. So it's been great to have these online consults, which are now legal in India since last year when COVID started. Closed comedones, patients can come only for closed comedones, but we know even the genesis of a closed comedone is inflammation at the level of the sebaceous gland. It starts with microinflammation leading to a closed comedone, which then will lead to a bigger lesion, which could be a papule, which could be a pustule. Then, of course, you always have the open comedones or the blackheads. So all of them have an inflammatory component today, as has been understood. And of course, we do know that inflammation, the target, of course, is the sebaceous gland and the sebocyte. And we have different receptors like the FOXO1 and the mTOR. And these are the two main receptors. So the FOXO1 is guided by androgens, and the mTOR is guided by dietary and lifestyle influences. And these two trigger off different growth factors and different inflammatory markers within the sebaceous gland, leading to inflammatory acne in all forms and all sorts. So, this was just a small overview I wanted to give of how today acne is perceived, and therefore, when we treat acne, my friends, it's very important for us to remember that we have to bring down the inflammation. The inflammation can be as overt as in this pustule, but it could be as subclinical and sometimes missed in a closed comedone. And that is why when we intervene to treat it, whether it's through a topical or whether it's procedural, sometimes you get an aggravation of it. So inflammation must never be underdetermined, and it should always be never be underestimated and always be kept in mind when handling any patient's skin when they come with acne in whatever form. Now, I'm going to present with you a spectrum of acne that I see in my clinic every day and over the years, and how we have understood it today and how we treat it. So, I've gone through age groups, and this is how I will share my experiences as well. So, adolescent acne has become extremely common. And the reason that adolescent acne is common is because age of menarche has become 9 or 10 years of age, even in a country like India. And of course, because of so many influences of social media, the children are far more, conscious of their skins. It's not like when we were growing up, it was, oh, you're growing up and this will pass off. No, nobody wants to take that as an answer. They want instant gratification, and they also want results. But more importantly, here is a 14-year-old female whose mother was not very concerned, but the child was very anxious about the acne. But if you see the acne, it's only grade 1 acne. But to her, it mattered because her self image was being marred by these lesions of grade 1 acne, which are predominantly comedones. We have to also realize that in this age group, there's a lot of dysmorphophobia, a lot of body image issues, and so they're very complex at this age. It's a very trying phase even for them. Actually, in her investigations, she had a raised TSH, she had a raised DHT of dihydrotestosterone of 900. Her ultrasonography already was suggestive of PCOS. Her fasting insulin was 28, and she had a gluten sensitivity. Now, we do know that certain foods are inflammatory markers for the gut and also inflammatory markers for the acne aggravation for those who are sensitive to it. This doesn't mean that everybody is dairy sensitive. This doesn't mean that everybody is gluten sensitive. But for those who are, you should take the history. So we always take a very detailed history. And today, we don't just take a classical clinical dermatology history for acne. We take a history which involves lifestyle, which involves diet. We take details of diet, details of exercise, protein supplements, makeup, cleansing. We even ask our patients about online products. I'll give you the whole list later. So there are also now reports out about milk being it's been published that skim milk can also sometimes aggravate acne in those who are sensitive to it. So diet advice now has become part of our prescription, lifestyle advice as well. What was our approach actually? All this child needed was reassurance that this acne is transient. It is a reflection of her fluctuating hormones. There's no need to get anxious. Of course, we have to treat her, but for a 14-year-old, apart from the reassurance, we gave her gentle products like dermocosmeceutics containing zinc, green tea, a bit of adapalene, definitely over here. Adapalene and clindamycin over here, it really works well in these kids. And they always want a good cleanser, they want a good moisturizer, they want a good sunscreen. So the sunscreens we prefer are those which are matte and a combination of inorganic and organic salts, or just a good zinc oxide sunscreen and a base sunscreen if they're very sensitive skins. And we also counsel them about hygiene and about how to apply products, and also we counsel them on how to cleanse their scalps, their faces, how much of product to take and how to apply it, which is typically, sunscreen is a fingertip unit, and just dab it all over and blend it in with your fingertips. Actives, any active we give, say adapalene and clindamycin at night, if we give it to them, we'll tell them to first moisturize their face with a fingertip amount and then take a small amount of the adapalene and clindamycin and just dot it. Say I tell them to take a peanut-sized amount and put 3 dots on the forehead, like in her case, 2-3 dots on the cheek, 1-2 dots on the nose, 1-2 dots on the chin. Just lightly blend it in. No need to rub, because in their anxiousness, they sometimes rub it in. And the dermocosmeceutics really appeal to these children. They're great products for maintenance. The ones with zinc, niacinamide, green tea. These are really very useful. And another thing that I do like to give these kids are nutraceuticals. We have some great combinations with zinc, vitamin E, green tea, kiwi extracts, some amount of the linoleic acid, or these also are known to be anti-inflammatory. So all of these are more towards being anti-inflammatory, and that's why the adapalene clindamycin combination works well in such children. Sometimes I avoid benzoyl peroxide because sometimes it gives them an irritant contact dermatitis. So this really works well. Now let's go to the next age group. This is a young girl in her late teens and early 20s. So this is an age group that comes often with very little acne, but when they come for their acne, they haven't seen what you see. We begin, and in our country, it's extremely common. Perioral and periorbital hyperpigmentation, which is very intense for such a young girl. And then when you go about questioning, you find they have erratic diets, sugar cravings, midnight snacking, and you'll find that I like to nowadays also take the BMI of such girls. And if you find that it's 27, they should ideally be 23 and under. You'll also find that often their fasting insulin is greater than 10. Actually, in this age group, the fasting insulin should not be more than 8, but 10 is the max I would allow them. Under 10 is what I tell them, but between 5 and 8 would be ideal. And this is what actually this hyperpigmentation that buries them, they call it tanning, too tan, dull, two tone look, dullness is all about a very subtle acanthosis nigricans. Some of them also have pre-existing pigmentary demarcation lines which get worse when the insulin is up and above 10. Some of them also have dihydrotestosterone levels which are normal but closer to the higher range, but their androstenediones are normal and their ultrasound is also normal. So this is a girl who probably may develop PCOS in the future because she's metabolically prone to it, perhaps because her DHT is already on the upper side of normal, her insulin is higher, she's already showing signs. But then there are also a group of girls who do not have PCOS, have such borderline PCOS, but may be genetically prone to having insulin resistance and may or may not eventually convert to having PCOS, which then you will have to follow up with a sonography, which is done in the follicular phase. And if the volume is greater than 10 cc's, you can monitor them over time, and you may need to eventually give them some treatment for polycystic ovaries depending on what they show. Especially if the DHT goes up, then you'll have to give an anti-androgen. Now, how would I treat acne over here? This age group actually requires more than anything else lifestyle modification, good diet, exercise, treatment plans, counseling. It's surprising that yes, a nutritionist can do the same, a trainer can do the same, a gym can do the same, but when it comes from you and you make a plan for them, which can be very basic but simple and doable, they follow it much better because they've come believing that you can help them. How would I treat her acne? Yes, I would like to give her benzoyl peroxide, 2.5%, and I would like to give her a little bit of glycolic acid or gentle retinoid. I'd also like to, at night, with azelaic acid. We do get in our country combinations of retinoic acid with azelaic acid, or we also get low strength 6% glycolic acid, either one of them. We do give at least, I give 3 to 4 times a week at night, and I alternate that with clindamycin so that it keeps the bacteria count under control. And in the daytime, I give them benzoyl peroxide to spot apply on the active lesions as they come. Along with that, good cleanser, sometimes in this age group, either a salicylic acid or a glycolic acid. 2% glycolic acid cleanser works well, along with a matte-based sunscreen and gentle moisturizer, oil-free moisturizer at night, followed by the actives. And these girls need follow-up. Let's look at adult acne, which is in this 35-year-old. So we're now going into the zone of adult acne, which typically is persistent scarring and with PIH, post-inflammatory hyperpigmentation. This lady over here, she's unmarried, and you can see she's got it all. She's got inflammatory acne, pustular, papular, she's got comedones, she's got scarring, she's got PIH, she's got erythematous scars, and this has been her skin for at least 2 years. And it has persisted. It keeps coming, keeps going, keeps coming every couple of months. She also has signs of early androgenetic alopecia. Her insulin was 18, and she kept her weight would keep fluctuating. And she had a sonography which had a left ovarian size of 12 cc. So clearly, she has polycystic ovaries. Her mother was highly diabetic, so clearly she was genetically prone to insulin resistance. Weight loss helped her a lot. Her acne improved. But these are girls who every 3 4 months keep coming back with an attack. Now, the two approaches here, attack of inflammatory acne, which tends to scar, so it's really disturbing for them. So here, oral isotretinoin does help, and sometimes you will have to combine it with antiandrogens, either cyproterone acetate and ethinyl estradiol combinations, or drospirenone and ethinyl estradiol combinations, or sometimes they just do very well on spironolactone, 50 to 100 mg, and you'll have to give the OCPs sometimes. So either you do that, and then you can give oral antibiotics and topical care like benzoyl peroxide. These girls actually do very well with the combination of adapalene and benzoyl peroxide combinations. They do very well. And then in that case, if I give that combination at night, then I give clindamycin in the morning. And in the long term, I like to give them have tretinoin 0.02% in our armamentarium in India, and that over a long period of time helps. Or we also give oral isotretinoin. Either we start with about 10 milligram, make it 20 milligram, and then slowly we go on to alternate day, 10 milligram, then mini pulse, and this they can continue for a long period of time. So this is how we would treat this kind of acne. Now let's go to adult acne in the 40s. So we've moved from adolescent to teens and 20s to 30s, and now into 40s. Now this is the bottommost photograph, shows a more severe case of her being when she first came. You can see it's scarring, it's inflamed, the multi-headed pustules. Then she improved, but that jawline, as you can see in the top line, the top photograph, you can see is persistent papules, you can see closed comedones, and these are grainy closed comedones, which we call sandpaper comedones, which typically indicate low-grade continuing activity of inflammation in the sebaceous gland, and this is a sign that typically this jawline acne suggests that there is a hormonal base for it. Either there is a testosterone sensitivity, end organ hypersensitivity of the sebaceous gland, or it may be a genuine androgen production with free testosterone being high, polycystic ovaries, there may be an adrenal component. So you've got to look at all this, and we got to treat that simultaneously. And you will find that in a lot of women, this area just never seems to go, even with oral isotretinoin. So they need longer courses. So let's talk a little bit about oral isotretinoin and the different methods of prescribing it. Back in the day when I started my practice over 25 years ago, now I'm in my 28th year of practice and loving it still, is that we didn't have oral isotretinoin. When we finally got it, we used to give the complete dose of 120 to 150 milligram per kilogram according to the body weight over 24 weeks minimum. And we used to hit hard and hit strong. And then what we found was that while that worked really well in our teenager cases or 20s, of course with consent, seborrheic cases, severe acne, we found that after 5 years, it could come back. They needed another 3 months after that of a shorter course of oral isotretinoin as per their body weight. But over a period of time, a lot of new regimens became popular, such as low-dose daily regimen for a few months. And then the cyclical regimen came, where you give it for 10 days with a 20-day break for every month for 3 to 6 months. Then came a mini pulse regimen of giving it only a small dose, 5-10 mg, on the weekends or 2 days of the week, Tuesday, Friday, or on weekends like Saturday, Sunday. So this is really the cyclical regimen, and mini pulse regimen works in women like her, because now she's 40, she's completed a family, so you don't have to worry. And so in a non-childbearing age group, and on whose family is complete, and who's either had a tubectomy or has the IUD or is on contraceptives, long-term isotretinoin really does help. In the previous girl, who was 35, she wasn't married. So in her, she didn't want to take oral isotretinoin. So the previous patient didn't want to take oral isotretinoin. And in her case, what we found was that we had to give her a 9-month course of anti-androgens, which helped her, but also we had to give her metformin. So in this patient, we had to give metformin. That helped us also. It helped her to lose weight. It brought her insulin to around 10, very stubborn to go below 10. At 35, to have an insulin of fasting insulin of 10 is fine. This is what we follow. And what we found that way was we could maintain her on a low dose of metformin, 500 milligram sustained release once a day immediately after her one meal, and therefore she could go off the oral anti-androgens. And she was on cyproterone acetate and ethinyl estradiol, initially also with spironolactone, which we tapered off. So metformin has become a huge drug also in the treatment of adult acne and inflammatory acne, with or without oral isotretinoin in these various regimens that I mentioned. So acne-prone skin. Let's see. You and I are talking to our patients. You and I in that doctor coat, and we are thinking antimicrobials, either oral or topical. Barrier repair, because now we all know about barrier dysfunction, even in acne prone skin. Zinc deficiencies can do that. Barrier dysfunction in atopics exists, who can also now get acne. Lifestyle, patients of rosacea who may have an acne overlap. Lifestyle influences like sitting in front of strong gadgets and blue light, visible light, personal habits, makeup. So barrier dysfunction has become huge today. And the way I talk to my patients about barrier dysfunction and repair is that your oil water balance of the skin has been compromised. And I tell them that when you use an oily skin product, you feel too dry and stretched. If you use a dry skin product, you don't feel like you're clean enough, your skin, and you tend to still break out. So they relate to that and say, yes, doctor. Immediately I know that I've got to give them ceramides, moisturizers with ceramides. The zinc will help them. They need anti-inflammatory agents such as the soys or the isoflavones. Niacinamide helps these patients. Of course, we do know that salicylic acid across the board is useful. The retinoids topically are very useful for long-term maintenance, clearance of acne. Even after oral isotretinoin is done, maintenance times oral isotretinoin somewhere around in their 40s, 35 plus, who may have a bit of scarring, then I would prefer tretinoin, or I would prefer a retinol or a retinoid or a retinol diide, depending on how sensitive the skin is. And I would like them to continue it with a bit of azelaic acid, because then they also get some anti-aging benefits, and the PIH and any pigmentary changes in the skin also get treated. It works as a great combination along with hyaluronic acid as a moisturizer, because that also has anti-aging benefits. So this is how we treat adult acne patients. Spironolactone I find to be a great drug. In fact, I find finasteride orally at 5 milligram. We're guarded when we give it, but it really works well for hirsutism and androgenetic alopecia. But for acne, it's a weaker drug. Spironolactone at anywhere between, we usually stay at 100 milligram. We are smaller people in India, so we don't give 200 milligram. We give 100 milligram either as start with 50, a week or two later make it 100, either 50 split up or 100 in the morning. If there's an adrenal axis, and 50 split up morning night is better. And we can give this for 2-4 months easily, with or without an OCP. Are, of course, the progesterone combination ones we tend to avoid, especially if there's a girl with PCOS. But some of them do better with the progesterone combinations, especially when they have very severe, long-standing menstrual irregularities. But for those who have more of a PCOS component, then we like to give cyproterone acetate or drospirenone with ethanol and estradiol combinations, and for at least 9 months. Sometimes we give it even longer, or if we give a break and the acne comes back, then we give it to them for about a year, a month's break, then another year with a month's break. These are really more refractory cases. So our patients are thinking whiteheads, blackheads, scars, marks, dullness. So when it comes to scars, today we all treat acne to prevent scars, and we all treat acne. If there are already pre-existing scars, we treat the acne and the scars both. We don't wait to clear the acne and then treat the scars. So that's where the procedural practice of treating acne really helps. It also helps with the PIH, whether it's hyperpigmented or even the erythematous PIH that we see. So let's go to the topicals in acne therapy. We talked about clindamycin, 1% lotion. You get a spray for the back now. And also the gels are better for those who have more sensitive skin, the younger ones also. But the younger ones really like the lotion, because they also can then couple it up with as a toner, but we tell them to put on a cotton pad and just dab it. Benzoyl peroxide has 2.5%, 5% we use regularly. They now come in different delivery systems and technology to make it less irritant, and it's working. And if the patient has a tendency to get an irritant contact, we tell them to do short contact therapy of just initially 20 minutes and then build it up, wash it off, and moisturize. Retinoids we just talked about. Adapalene we're using regularly and great for long-term maintenance. Tazarotene I have used but I've used it in extremely seborrheic skin with a lot of comedones, closed and open comedones, and especially in the younger age group. But also between adapalene and tazarotene has anti-aging benefits, but there are studies for it, but it is not very well tolerated. So the retinoids, like tretinoin-based ones, are more tolerated. Then, of course, adapalene comes in all its combinations, which you discussed. Azelaic acid, a great molecule. Dapsone gel 5% is available in our country. Great for inflammatory acne, especially cystic, nodulocystic acne and adult acne. And then, of course, we have the AHAs, the glycolic acid whole series, 6% from 2% to 12%. Salicylic acid anywhere from 1 to 2% to 3 to 4% up to 6%. Of course, when it goes into 30%, it becomes a peel. Then we have lactic acid and lactobionic acid, which are great for sensitive skins, both young as well as adult skin. And now we have a new generation polyhydroxy acids, which are larger molecules, don't penetrate so much, don't cause so much irritation, good for sensitive skin. Great as also post acne recovery. In post acne recovery and in procedural practice of acne with lasers or peels, they work very well in tandem to continue the renewal exfoliative process and really do help in the constant in the dyskeratinization, and therefore the patients end up with fewer comedones. Zinc and niacinamide are great add-ons. They come as a gel. They come in many of the biocosmeceuticals, which are marine and botanical, as well as the other cosmeceutical agents, green tea, grapeseed, zinc, niacinamide. These are really very popular, and isoflavones are very popular, and these are great adjuvants. They're not the cornerstones in treatment of acne. They're adjuvants. They're great also for adult patients, and they're great in the maintenance plan. So when we treat our acne patients, we always give a maintenance plan. So we have the immediate plan, then we have the other, which is to the medical and the clinical aspect. Then we have the procedural plan, if required and if desired. And then we have the maintenance plan. And our maintenance, so we actually create a blueprint for our patients and walk them down it right at the first consult and tell them acne takes time. You give it at least a couple of months, but nobody wants to give it a couple of months. So if you add on the procedural practice, then you can tell them within a month you will get much clearer skin, but you have to maintain. So the maintenance will be products, skincare products, any cosmeceutical agents, and the actives, and oral if at all, either the anti-androgens or a slightly longer course of oral isotretinoin. So this is how the whole plan for acne forms, along, of course, with sometimes the nutraceutical agents. So what is my checklist? These are a few of my favorite things. One is oral isotretinoin and history. So this is my checklist when talking to a patient who comes to me with acne, is that I always ask them for oral isotretinoin, current and recent past usage of it, how much they have taken, how much it helped them, why it may not have helped them. I always ask for past procedural history when a patient has come. Patients are always doing do-it-yourself DIY and home remedies. So I always ask them in my history. These are all the new add-ons which I've added to my history sheet when a patient of acne comes. Of course, in COVID, we ask them for mask hygiene. We ask them what type of mask they use, how often they wash them, use them, and mask hygiene has become huge because of maskne. Salon activities, I always ask them for recent or past salon activities. We also ask them for laser hair removal because sometimes they come with an aggravation post a laser hair removal session. Topical steroid use, I always ask them for because this can sometimes give a confounding picture, and if you miss steroid acne, it can be steroid induced acne, you may miss a huge diagnosis and end up being unsuccessful. And of course, the huge impact of social media with online therapy and purchases, especially in this 1 year of COVID, there's been a huge number of DIY home remedies and online therapy and purchases. So do talk to your patients about, are they using a scrub, are they exfoliator, micellar water, sheet masks. This has all become part of the way patients look after their skin. Acne patches. So one very novel formulation that has come out is a hydrocolloid material or salicylic acid in a acne patch, which some of them have biodegradable microneedles which you can stick on. There are day patches, night patches, great for camouflage. You can put makeup over, gives the patient confidence. They don't pick on it. So these little acne patches have actually become great add-ons in our, those little go-to products that our patients are looking to us for in guiding them. So we need to give them guidance even on the online therapy and purchases. What about lifestyle changes? Chai is very popular in India. It is actually our national drink. And of course, we tell them not to have sweet tea because each cup of sweet tea could have even 2 teaspoons of sugar. So we do not want a high glycemic index in our patients with acne. Studies have shown that rich fatty foods, sugary, high density, refined sugary foods does flare up through the mTOR pathway and creates inflammatory acne in those prone to it. And insulin resistance is very high in our country because we have a high incidence of diabetes. So anyhow, chai pe charcha means let's chat over chai, let's chat over tea. Basically, it's all about counseling. So we talk to them about how they can achieve a lower glycemic index diet. We give them nice options. We tell them to add more protein in their diet. We talk to them about exercise options. In fact, a lot of people are taking protein shakes. So they do show that some of these shakes can also have this inflammatory acne can get worsened because of the mTOR pathway activation. Stress management, of course, is a whole topic, but of course, we need to talk to them about it. And of course, their sleep patterns, which have gone completely haywire in this last year. And of course, the effect of visible and blue light also on their skin health. Diet. So, as I said, these high glycemic index foods, dairy products, saturated fats, we need to talk to them. So it's basically shown that the disinhibition of FOXO1 and activation of mTOR causes stimulation of the sebo-regulatory factors, the inflammatory factors, and the diet-mediated changes in sebum quantity causes overgrowth and biofilm formation of P. acne. So this is why we get stubborn, resistant or antibiotic, topical and oral antibiotic resistant cases of acne which keep relapsing. And one molecule which is good for biofilm formation topically is mirtazapine, and this is available as a topical. And so we first tell them to apply it as a topical and then put the active on top. Sometimes does help. So does zinc topically as well as orally. So that does have some role to play, but not in every patient, but definitely in those who are prone to metabolic and hormonal issues. Let's talk about relapsing acne. Repeated prescriptions of oral isotretinoin still keeps coming back in forms of nodular cystic acne, adolescent, repeated pustules and papules, hormonal acne more along the jawline, adult acne with scars. So what is our approach? We like to think about the energy-based devices for such patients more than peels. So in the younger age group, medifacials and peels actually do really well. But as they grow older, get more relapsing acne with scarring and deeper inflammatory nodular cystic lesions, the energy-based devices and lasers really do help. And you need to do at least 4 sessions, if not more, but usually 4 sessions, 3 weeks apart. Microneedling RF, fantastic. Not only helps the scars and a multiplicity of scars, but it also helps active acne. There are a lot of reports to say that it helps in reducing the repeated attacks of acne by shrinking the deep RF energy. You'll probably have to go to 2.5 to 3 mm and deliver the energy there through the microneedling. Helps to shrink the sebaceous gland and deactivate the bacteria out there with the heat. And microneedling, we've had great success. Of course, if there's active acne, then we do give oral antibiotics or we give a low dose of isotretinoin, about 10 milligram. We work with 10 milligram for lasers, even for all of our peel patients, medifacial patients. We do give low dose isotretinoin and we work with it because it has great collagen remodeling benefits and it aids in better healing and keeps the outbreaks under control. Nowadays, a picosecond laser has been useful not only for the pigmentation left behind but also for the scarring type of acne. We have the erbium glass 1540 nanometer vacuum assisted handpiece on our system, and this has been found to reduce the inflammatory acne and scarring. We also use the short pulsed Nd:YAG laser for erythematous scars and grade 2 acne to bring it down faster, along with topicals and orals. The IPL, intense pulse light, with the vascular filter. We have found very useful when there is erythema, and also for quicker clearing. So the short pulse NDI and the IPL gets very quick clearing within 2 or 3 sessions. The patients feel happier, better, and their skin also has a much better appearance. And laser toning with the Q switch NDI we do when there's a lot of hyperpigmentation, because in our country we get hyperpigmentation very easily, or for acne excori when cleared up and those very stubborn pigmented marks, the laser toning works well. Very gently we give do about 4 sessions, maybe sometimes more, of laser toning once every 3 weeks. So these are usually once every 3 weeks, along of course with a medical plan. And sometimes we use these laser, we alternate them with peel. So once it will be a device or laser, then the next session is a peel till the inflammation, the hyperpigmentation, erythema comes under control. Then we continue only with the energy based devices and lasers, or then they switch on to their maintenance therapy. Let's look at some cases. This is a case of relapsing acne. Despite completion of oral isotretinoin course, would peels help? Yes, there is one peel that we have found to be useful, and that is the black peel. We do 2 black peels. This contains jasmonic acid and it contains KOH, and it has the black acetic acid, the jasmonic acid, and the KOH. And this is done 3 weeks apart, and then we will continue with lights or lasers, about 4 or 8 sessions, and we found that to be better. And in this case, we could take him off the isotretinoin eventually, but after he had finished a full course of isotretinoin at 150 milligram per kilogram of his body weight for about 6 months, he kept coming back. So then we went on to 2 black peels and the lasers and lights, and we were just giving him 10 milligram of oral isotretinoin, and then finally we could take him off it. But I know, and I think we all know, that it's likely that he may come back in a couple of years with another outbreak. It's possible, especially when you have it so much in the beard area, because the hair follicles are so thick, and eventually the bacteria may start regrowing, they repopulate, and may cause problems of inflammation again. Now, persistent erythema, we could either do a chemical peel. A treatment of choice here would be a glycolic acid peel. We also do a lot of the gel-based peels, mandelic acid, phytic acid. These also we have found to be useful. If it's a very seborrheic skin, we do a salicylic and a azelaic acid combination peel, and then we move on to do the short pulsed NDAG as I described, and we use the 300 microsecond mode pulse, and we do it at about 9 to 10 joules with a 5 millimeter spot size, and we pass around 400 shots over here, and that's how we do it. And we call them every 2 weeks, and it really helps them. And the chemical peel we do first to bring down the inflammation. Remember, in a lot of these cases, there's a lot of subclinical inflammation. So you need to bring down the inflammation. Of course, you're giving them medical management. That goes without saying. But if I was using a retinoid out here, I would stop it 2 days before a peel or a laser treatment. And then I would start it 2 days after. And I would just give an antibiotic here, but I could continue with zinc and niacinamide. That really helps over here, or azelaic acid also helps. Here, azelaic acid helps really well, and here the peel would be more of a tretinoin peel with some brighteners in it, arbutin kojic acid, or we could also do a mandelic acid peel initially, and then we could also go on to using the ferulic acid peels, which are retinol based. And then the Q switched NDAG really helps here, or a picosecond you can start off right away, because it would help both the pitted scars as well as the pigmented scars. So acne excori today we can treat much faster, otherwise it could take for months for the pigmented areas to heal. So it's all about our patients and what they desire. They want improved texture of skin, reduction of pore size, reduced oiliness, less clogging and comedone formation. And so this is also where the lasers and energy-based devices help. But eventually, in a maintenance plan, or if the patients are very young, the medifacials such as hydrojet, oxyfacial, 3D fusion, fire and ice facial, all of these are really wonderful to help to keep the exfoliation, even at a micro exfoliation and process, and keep the brightening effect. And but this is only if the active acne is under control. Let's talk a little bit about the new variants. That's maskne and bacne. So this is a case of maskne. As you can see, in fact, she has a rosacea component as well. So the treatment of maskne is not very different, except that mask hygiene has to be stressed upon. We tell them to use matte makeup and not to use very glossy lip glosses and lip balms. And we tell them to change their mask if they've sweated a lot. And over here, clindamycin, benzoyl peroxide, and adapalene would really work. And these are things you can even give them on a long-term basis. I also like to give them the micellar waters. That is a very nice cleansing. As we all know, micellar waters are cleansing products which are oil molecules in a water base, and put it on a cotton pad and then wipe the skin off. It helps to degrease faster, but it's also very gentle as opposed to a toner which is alcohol based and may irritate. Sunscreens. Also, I tell my patients to use the silicone based sunscreens if they're wearing their mask for long hours. Like we doctors use our masks for 10, 12 hours in the clinic. So I use a silicone based sunscreen so I don't get sweaty and sticky underneath and clog up. So, but however, now, we do see a lot of large comedone formation as part of maskne, like here. You can see this in the chin. You can see these huge papules. Here, of course, ILS would work. The acne patches work here. And here, a good topical antibiotic regularly and dapsone gel would work really well. So clindamycin every day. Maybe they can put a clindamycin lotion or a gel and then wear their mask, and then come back and then they can apply a retinoid, or even the dapsone gel at night helps. And you could also do a peel. Now, the Urban Glass vacuum assisted 1540 nanometer has an advantage of not only treating the inflammatory acne but also helps in clearing the scars more easily, which we know that in acne you do get a lot of scars. So it really does help even after 2 sessions and then 4 sessions. So in resistant acne, we do use this laser particularly, and the topicals and peels either cyclically or in combinations, which we can also discuss in the question answer, are retinol and pyruvic acid, mentalic acid, are very useful. They come in combination, and a combination as peels. Lactic acid for more sensitive skins on the face, arginine also, or you get the arginine lacti combination peels, amino fruit acids, phenols. We use a light phenol and TCA peel when there's a lot of hyperpigmentation on the back left behind by acne, and then follow it with a few Q-switch lasers, laser toning. Azelaic acid is one of our favorites. Ferulic acid, especially when there is adult acne, in combination with a bit of retinol. The black acetic acid, jasmonic acid for very inflammatory acne. Kojic acid and arbutin are great add-ons to any peel. You can either add them on as a separate, or they come as part of the whole peel. And for sensitive skins, we do also dry climates, the gel based with a higher pH stay on. Combination peels work well. They can stay on for about 4 to 5 hours and then wash them off. And we do know that that the various aggravators are changes in sebaceous activity and hormonal levels, PMS, and premenstrual acne. I like to give 7 days before oral P6, oral evening primrose oil, and a bit of clindamycin at every night to help to prevent, calm down some of that inflammatory acne, and I tell them to control their cravings. The dietary cravings, high humidity conditions, especially in our country, local irritation, friction, occlusive clothing, especially for acne, types of mask, hygiene, storage, also very important. Cosmetics which have a greasy base, they should avoid. And these are the various dietary items of chocolate nuts, fat cola, carbohydrates, and also hair products. So to remember, serums, hair serums, and various styling products which they use on their hair, leave the hair open, touches their face. All these are known aggravators and can give a lot of jawline acne. So my take-home message is that acne is a sensitive marker today for insulin resistance and metabolic syndrome. So do look out for these if you find associated symptoms of sugar cravings in the history, acanthosis nigricans. They have early hirsutism, hair loss, itchy scalps. So or they also have acne on the face as well as on the back, or very persistent acne. You'll know that there is something underlying. Acne persistent to standard therapeutic options. Look out for systemic triggers, including diet, and also remember steroid-induced acne. Now, the most common condition with hormonal association is PCOS, polycystic ovarian syndrome. Manifestations can start as early as in the adolescent age group, and if we follow early skin signs, early correction and prevention is possible both of the acne, so they don't have to suffer and go into bad acne, and prevention of scars to give more skin confidence to our patients. Balanced nutrition and physical activity has now become part of the whole acne plan. So, maintenance is key with counseling, hand holding, judicious use of procedures as we've discussed, and of course, like today, learning and sharing is the key to a satisfying acne practice, and that's what I really look forward to in the question and answer session. Thank you very much.
Thank you, Dr. Kohli, for that session on acne management. You have very beautifully taken us through different treatment protocols for different acne lesions, different skin types, also for different age groups. You have taken us from the adolescent to the 40-year-old. So it's a very exhaustive and very beautifully put treatment landscape. Thank you very much for that. There are a few questions from the audience. The first question that I would like to address is from a doctor from Baghdad, and he wants to know the role of biologics in severe cystic acne management in your practice.
So it's a great question. And honestly, I don't use biologics in acne because so far we have been able to manage most of our cases. I use the word most because there are some cases who just don't respond and keep relapsing. But that was back in the day. And that time we didn't have the biologics. But today, I think the procedural management of acne has helped us to mostly overcome, and better understanding of the hormonal aspect of acne has helped us to overcome using biologics. But yes, there are acne fulminans cases, there's tropical acne, there's some very resistant cases, but honestly, I have never used biologicals.
Okay. Thank you, ma'am. The next question is, can we combine ND-WAG laser 532 nm and a combination of adapalene and clindamycin in acne patients, and which would be the patient population, whether it would be mild to moderate or moderate to severe patients?
Mild to moderate, I would use 532 because 532, at least in our skin type, can cause PIH because we have a lot of melanin in our skin. I guess in your country, you're more lighter skinned. Most of you are more lighter skinned, but you have to remember that there's a lot of inflammation. So I would do it for mild to moderate, or if it was a severer case, I'd bring them down with oral antibiotics or oral isotretinoin, make bring down their grade from severe to moderate, like from grade 4 to grade 2, and then start using the 532. And yes, I would definitely combine it with adapalene and clindamycin for long-term maintenance and in between the treatments as well. And the advantage of the 532, it has a vascular, the target is the chromophore is vascular hemoglobin, so it would work well. But in our country, we're careful only because of the PIH that we can give our patients. But maybe that's not a problem in your country, so you could, yes. That's why I like the short pulse 10 because it has that advantage of being a shorter pulse, so it works at a higher level. And NDI also has vascular affinity, so that's how it helps the erythematous type of acne and scars.
Thank you so much, ma'am. The next question is, what is your treatment approach for lesions of papules and scars, or specifically on the nose?
Yeah, that's a great question again. Uh, Papules and scars on the nose, I think I would start looking at two, three things. First is, I think that usually these patients have a sebaceous hyperplasia component, which means that repeated attacks, or they usually have very large sebaceous glands here, and they get larger lesions, nodular lesions, nodulocystic lesions, repeated attacks. So they end up with scarring. And that scarring is a sebaceous hyperplasia because the oil glands with continual attacks of inflammation get hypertrophic, and then they look like these bumps. These patients may have a rosacea component, and they may also have a dietary aggravation. So you need to control inflammation from diet, if at all, You need to look at the rosacea component. You need to give them a good sunscreen. They also do, these patients do well with Dapsone gel, azelaic acid, and zinc and niacinamide, so good topicals and a good sunscreen. And then, because you don't want repeated attacks, and then I would take my ablative RF, my Elman Surgitron. I'd put the ball tip probe on it. I'd put it in cut and coagulate mode, and then I would individually, with that ball tip, and just go and punch in all the sebaceous hyperplasia lesions, which then shrink because the heat of the RF, ablative RF, shrinks it. And as it shrinks, it flattens it. And then once it heals after about 3 weeks, it takes about 10-15 days to heal. I give topical dressings and help it to heal. And then I would use a resurfacing laser, such as I don't use the CO2 again, and my patients don't want any downtime. So then I would use my erbium YAG laser, or if I have a picosecond, I can use that. But a erbium YAG laser or microneedling RF. These are the two things I would do to further flatten out and try and get them totally flat and flush with the skin. The trick is not to go too deep with that ball tip with your ablative RF. The trick is to just go enough into the mid dermis. If you go deep dermis, you're going to cause a pitted scar. So this is how I like to treat these kind of lesions on the nose, if I've understood the question correctly.
Yeah. Thank you, ma'am. Ma'am, the next question is, in a patient who is aged 35 years old, unmarried, would you still advise to use oral isotretinoin? And what precautions would you take? This is from Dr. Kanika. This is from Dr. Kanika.
Sure. Hi, doctor. Thank you for that question. If she's 35 and she is then I'd counsel her and I would tell her that she has to inform me or stop it as soon as she knows that she has some plans. And we do take consent, of course. And then it's fine because if she has, if she's already engaged or has a very recent or a very her marriage plans are very close by, then I would not give it to her. You need to take good history from your patients, and it's better to be upfront, with your patients and tell them, look, this is the drug you're taking. What are your plans? Because this is what you have to be careful of. And patients are very, sometimes they say, no, no, nothing, 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 everything, nothing's going on. I'm absolutely fine. I want to take the drugs. So many people have taken it. It's worked for me before. I want to take another course. So then they know what they're taking and what they have to do. But if she's not, if this 35-year-old was married, then I would never give her an oral isotretinoin unless she is on birth control or has an IUD. Even if she has no children or even one child, we don't know if they make their plans. We don't know if they goof up and she gets pregnant. And a 35-year-old who's married, I would never give oral isotretinoin. I'll give antibiotics, whatever. But if she has an IUD or she's on birth control, 1 month after the birth control, I would give her isotretinoin.
Thank you, ma'am. The next question is by Dr. Asaf. His question is, what would be the right isotretinoin dosage to start off with and maintain? And normally the treatment effect, by when should we actually see the treatment effect? And what are the problematic side effects that we normally have to be a little bit wary of?
Sure. So the problematic, I'll take that first. The problematic side effect is actually, it's at any dose. See, I have to say this. It's not that at a higher dose you get a lot of dryness. There are some patients who get dryness and even at a lower dose. Their lips get dry, their skins get dry, and that's something I counsel them. This is the drug you're taking. The first thing I tell them is if you don't get dry lips, it's not working. So expect to get dry lips. I give them a lip balm. I tell them you're going to be sun sensitive. Don't go out too much in the sun. If you're planning a sun holiday, stop it. For the time that you're in the sun, it'll make you photosensitive. I give them a skincare plan with a sunscreen, a moisturizer, and a lip balm to suit the isotretinoin schedule. Then they don't suffer from excessive dryness. Then they don't get sunburnt. I counsel them about headaches, body ache, but I think the one thing that patients really get very affected by is that the acne gets worse in some patients. So it's known that in the first 2 weeks to even sometimes 2 weeks, you can get an aggravation of existing acne. So if there's a lot of inflammation and a lot of pustules, then I first give a short course of antibiotics, and my favorite is actually in the macrolide group, like the azithromycin or deoxythromycin. And once, because they also have an anti-inflammatory benefit, once I bring down the inflammation over a week, then I start the oral isotretinoin slowly, and 10 milligram for 10 days and 20 milligram for 10 days, and build it up, or they stay on that dose. Then they don't get that exacerbation of acne. That is extremely distressful to patients. The other thing is, it is dose accumulation that leads to further oil gland shrinkage, and that's when your seborrhea comes down, the oiliness comes down, bacteria to keep proliferating and growing. And that's when your inflammation will come down, and that's when you'll have your begin to really see your benefits. The other thing they say is, but the acne has gone, but the scars are still there. So you have to tell them it's not the treatment for scars. It helps to soften your scars. It may lighten them, but scars is a totally different ball game and a different treatment plan.
Thank you
And
very much, ma'am.
the dose is variable, but I think overall, I used to start at around 20 milligram, and then I used to build it up to 30, or from 20 to 40, or 20, 30. Back in the day, I used to start with 20, and then I would build it up to 40 over 2 weeks, maybe a month. And then I would keep them on a dose of zero point 0.6 milligram per kilogram, or I would keep them at a dose of 120, not exceeding more than 120, and at about 0.6 milligram per kilogram is good for acne. For hidradenitis suppurativa and those conditions, we give 1 milligram per kilogram. So the thing is that now, however, I've noticed one thing, that the amount of sensitive skin we see nowadays, even with acne, atopic patients are getting acne. Dry skin patients are getting acne, because today's acne is all about inflammation. There are different triggers from external to internal, that sometimes we have to start on a very low dose and build it up. So we start on 10 milligram alternate day and build it up. Now, if you have a patient with very severe acne, like an acne fulminans, you can't start oral isotretinoin. You probably sometimes have to give oral antibiotics and oral steroids, bring it down, and then start the oral isotretinoin. Otherwise, you can get a granulomatous reaction. So these are all the variations.
Thank you, doctor. There's one more question with regards to a combination of oral isotretinoin and a topical agent. So, which would be the best topical agent to combine with an oral isotretinoin if it is required?
So with an oral isotretinoin, I usually don't give a topical retinoid. They don't go together. The dryness is too extreme. Then patients get peely, and they really don't like it. With an oral isotretinoin course, I like to give, if there's a lot of inflammatory acne, erythema, some PIH, I like azelaic acid. In the early stages, if there's a lot of inflammatory pustules and all, I may give dapsone gel and azelaic acid. But if it is a teenager, very often my choice is oral isotretinoin and clindamycin. So because the skin is going to get dry, I give them a moisturizer, but I also prefer clindamycin gel. And I almost make them use it for the first 3 to 4 months every night over their moisturizer on the affected area. I tell them to use clindamycin gel. That with oral isotretinoin I found to work really well in the bacterial, those pustules, and somehow keeps the bacteria under control. After 3 to 4 months, you don't know, antibiotic resistance may develop. That's when they can switch to benzoyl peroxide. So
Thank
for
you,
the
doctor.
teenagers, this is what I prefer. The adults, I prefer dapsone gel and azelaic acid, because it's different acne.
Yes.
The acne genesis is different.
Thank you, doctor. The last two questions we would be addressing right now. One of the questions is, if a patient has severe acne and refuses to take a dapsone, what type of treatment can be given in such a case? This is by Dr. Karima from Baghdad.
Or I guess she's asking about oral dapsone.
Yes, yes.
Yeah, so oral dapsone is a great drug for nodular acne, and especially also backne, persistent back acne. It's very useful, but dapsone has a whole sulfur sensitivity issue, so a lot of people don't give it. But what was the question? What would I
Uh,
give if the patient does
if
not?
yeah, if the patient refuses to take dapsone, what would be the next treatment option? Or even if she refuses to take any other kind of orals, for that matter.
Right. So then procedural management of the acne would, because it goes deeper, and then microneedling would be my first choice. Microneedling RF, not microneedling alone, microneedling RF.
Thank you, doctor. The last
And
question
it's got to
would
go
be,
deep. You got to use the needle depth should be 2.5 to 3 with a moderate energy pass, depends on the kind of machine you use. And if you're using insulated or non-insulated, actually the non-insulated needles are better. You need to do only one pass, even 2.5 or one pass of RF, microneedling RF with moderate energy, with a little longer, impedance, will really help. You want to pass the
thank
energy for a little longer, but in a moderate level, because you don't want to irritate it. You only want to pass the energy longer to shrink it,
okay. Thank you,
causing
doctor.
the blood process. Yeah.
Causing the you said causing the last part was not audible, doctor.
You're talking to me?
Yeah, yeah, yeah.
Sorry.
Causing is
I
the
said
last
that,
part is
yeah, I said that the reason you want to give a moderate energy, but with longer impedance is so that you can pass the energy in a moderate way for a longer time. You won't cause any unnecessary fibrosis. You will also not
okay.
cause too much of heat inflammation and any what do you call it, aggravation of the acne, but you will be able to shrink the oil gland. You'll be able to also help scarring and help with the right kind of dermal remodeling, and also the right kind of shrinkage without worsening any scarring, and help the scarring as well.
Thank you, doctor.
Yeah.
The last question is, if a patient has severe nodular cystic acne and liver disease, what would be the treatment of choice?
Severe nodular cystic acne and liver disease.
Yes.
Imagining this would be, could this be cirrhosis or one of those kind of things, or some
Yeah.
sort of hepatotoxicity?
Yes.
Well, we don't have much left in your kitty. So I think, again, I think long term maintenance with a topical retinoid, and maybe you can use the stronger topical retinoids. I mean retinoid and higher strengths.
Okay.
And you could give, and you could do actually some procedural management depending. And then later on, you could maintain, you call the patient back every 3 months and give them maintenance treatments. So procedural management would work, or just eventually long term usage of, slightly build it up from lower to higher strengths of topical tretinoin. Tretinoin would then be the gold standard in treating such cases, along with, probably you'll have to rotate your topical antibiotics. You'll have to give clindamycin then. So here again, benzoyl peroxide, no resistance is known to benzoyl peroxide. So, if you have a good formula without any topical irritation, then you can give benzoyl peroxide. After 3 months, you can give azelaic acid, come back to benzoyl peroxide. So you'll have to rotate. You'll have to give a cyclical regimen. And sometimes, when very severe nodular cystic acne, we do give even rifampicin. But again, if the patient has hepatotoxic disease, you're going to be careful about rifampicin. It's also one of the drugs that is given.
Thank you, doctor. So with this, we have addressed all the questions that have come across. Thank you for taking your time. We at Ajanta would like to thank you for your insightful guidance regarding the treatment landscape and giving the different treatment algorithms for different types of lesions of acne. Also, I would like to take this opportunity to thank all the doctors who are attending this webinar and hope to see them in all the future webinars that we would be conducting. Last but not the least, I would like to thank my technical team who have made this very successful and a very smooth running scientific platform. So thank you, the technical team. Thank you, Dr. Malvika, once again.
Thank you very much, Dr. Shirley, Ajanta Pharma, and of course the delegates. It was an absolute pleasure to share. But I must say your questions were amazing, fabulous. Really, I think you really have a great acne practice, and you're doing a great job because your questions were really good, and I really enjoyed answering them. And thank you, Ajanta Pharma, International Division, Dr. Shalini Kumar, and all of you, the AV team, for this wonderful, seamless experience.
Thank you.